Good evening. I would like to welcome you to tonight's virtual webinar titled Advanced Laser Techniques for Achieving Optimal Vascular Outcomes. If you have questions during today's event, please enter them in the Q&A box. We will answer as we go along. If you encounter any issues with the video or connection, please refresh your browser, as that will often fix minor issues. Google Chrome is the preferred browser. This content is intended for global training and educational purposes only. Candela Corporation and its affiliates make no representations regarding federal, state, local laws or regulations that might apply for use and operation of these devices. For this reason, please review your country's current indications for use as provided by the respective regulatory agency. This content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Treatment considerations are under the discretion of the qualified licensed healthcare professional. Individual healing times, discomfort, treatment results, and satisfaction can vary. Now I would like to present Dr. Didac Barco, our moderator of the event. Dr. Barco is a Barcelona-based dermatologist with master's degrees in aesthetic dermatology and lasers. He has trained in the UK and US and lectures on laser therapies at the University of Alcalá and University Cardinal Ferreira. Dr. Barco also coordinates education at Forium Dermatology in Barcelona and has published extensively on laser treatments for scars. Dr. Barco, the floor is yours.
Thank you so much for your introduction, Aviva, and thank you to Candela for counting on me to moderate this wonderful roundtable. So this is the panel of our experts. We're later going to introduce them one by one. And the first thing to do is a brief introduction on the topic that we're going to speak about today, which is vascular lesions. And I'm just going to zoom in a little bit about their singularities. So the first one to take into account is that most of the vascular lesions do have different depths, as we can see in this scientific paper, because different types of capillary malformations show, as said, different depths. So if we see a macule, we probably have the main lesions on the upper dermis, but if we have a purple and papular spot wine stain, we may have lesions not only in papillary but also into reticular dermis. And finally, if we have a nodular polar white wine stain, these lesions can achieve very deep into the reticular dermis and sometimes even to fat. So this is one of the features of vascular lasers, and it means that to reach different depths, we may use different wavelengths. So for example, as we see in this case, we could use different wavelengths, for example, with a Norlis device to try to achieve the best depth to treat each and every one of the parts of this capillary malformation. So here you see precisely a capillary malformation treated with just one single wavelength. And we see some areas where the response was excellent and they had complete clearance, but some of them did not reach enough depth, so the lesion was insufficiently treated. And in other places, they tried to push the settings of the laser using the same wavelength, and they caused some scarring. So it's a good idea to take into account the different depths that has a vascular malformation, to use different wavelengths to achieve all depths, right? One of the advantages of the Norlis device is that in just one single device, in just one single system, you have different wavelengths and you can reach to different depths. And that's one of the features that makes this device very ideal for this type of treatments. So with just changing the handpiece, we can reach to different depths. And this is one of the questions that I would throw to our speakers. So how do they manage to reach different depths with the platforms, with the systems that they use? So this should be the first question, and they will dive into it. And there's also a second feature about vascular lesions that we have to take into account, and it's that session by session, they start losing chromophore and the color of the lesion fades away. So in every session, it's more difficult to treat this lesion because it has less target. So it may be interesting for us to take the maximum profit or the benefit of the treatment to use 2 pulses in every zap that we do. The first pulse transforms oxyhemoglobin to methemoglobin, and this second one has more absorption of the light, so we can take profit of converting oxyhemoglobin with the first pulse into methemoglobin, and with the second pulse, this latter is going to absorb the light more properly. So this is the second question that I would throw to our speakers. How do they deal with the different systems to make sure that they obtain the best result, not only in terms of wavelengths, but also taking profit of methemoglobin? So this should be the brief introduction, and now we're going to move forward to introduce Dr. or Professor Peter Bjerring, who is a board-certified dermatologist from Denmark with over 250 scientific publications and 500 international presentations. His main interest is laser and IPL treatments, and he has held various leadership roles in dermatology and is currently a clinical professor at Aalborg University Hospital. He is a past president of the European Society for Lasers and Energy-Based Devices and a fellow for the European and American Dermatology Academy, and also a member of the American Society for Laser Medicine and Surgery. What a CV, that's an astonishing CV. So Professor Bjerring, we will be very pleased to hear about your speech, so you can proceed.
Thank you very much. Thank you very much for this very fantastic introduction, and thank you to the Candela Corporation for inviting me to talk about the Nordlicht system, which is very close to my heart. I'm going to talk about this system, which actually contains different light sources, and I'm going to expand a bit about that. First of all, why is it named Nordlys? The reason is that the system is actually designed here in Denmark, where I live, and Nordlys is the Danish name for northern light or aurora borealis. So why should you use a platform device like the Nordlys system here? First of all, you can attack different treatment indications with this single device, which means that the initial investment is lower compared to buying several lasers to do the same work. And again, different indications can quickly be treated in the same session. And you don't need a large room because the Nordlys system replaces at least 4 different lasers that would take up much more space than one platform device. The Nordlys comprises of 4 different devices. First of all, intense pulse light, which is flash lamps. I'm going to in detail in that in a moment. It contains a neodymium YAG laser, a non-ablative fractional laser at 1550 nanometers, and a non-ablative fractional laser at 1940 nanometers, as we can see here. First of all, IPLs. The history of IPL started in 1992 with the photoderm, and then there was a long and winding road until we reach at the Nordlys system, which is the most advanced system in the market now. I was so lucky to take part of this journey with the Nordlys here, as you can see from the first relaxed light, and the technology has been improved and refined over the years, and now we've got this Nordlys system. The most important thing about the Nautilus system is that we actually produced peer-reviewed publications for each clinical indication for this device. Here you can see the first 8 of these publications we made, and these are the rest of them. All in all, 13 different indications that are specifically addressed by peer-reviewed publications. A little bit about the technology. Laser light is monochromatic, it's coherent, and it's parallel, while the IPL light is a polychromatic light source. The light is incoherent and it's unfocused. That means that we need to put a couple of filters in front of it in order to reach the chromophores that we want to treat in the skin. IPL are produced, the light is produced by flash lamps, and we need these colored glass filters to filter the wavelengths out we don't want. We also use water as a filter because water absorbs from 950 nanometers and further out in the infrared light source. So if we use water around the flash lamp here, we already filter these wavelengths away, so they will not be absorbed in the tissue afterwards, making non-specific heating of the tissue. This is in a position to other devices with no water filter in it. There are many different wavelengths that can be produced by clinical lasers, but as you can see, the Nautilus will range from 400 nanometers all the way up to 950 nanometers with this IPL system. And that is actually a very good idea, because in the Nautilus here with the selective waveband, we filter out the wavelengths that are absorbed in tissue water, and we don't heat the water. That means that we don't need any skin cooling compared to other devices where you actually apply a much larger amount of energy. And there are many different filters to choose between at the Nautilus system here. And we'll go a little bit more in details because of the different indications. The optimal treatment requires selective photothermolysis. And that means that we have to control the waveband, the wavelength that we're using, control the pulse duration, the amount of energy, and also the treatment technique, which is actually quite easy to learn with the Nautilus system. It has a built-in clinical intelligence because we have worked a lot on finding the right settings. So you only need to use the screen to enter the skin type, the degree of suntan, and the target size that you are attacking. And then the Nautilus system will calculate the pulse time and energy settings, which means that there's a very short learning curve and you can easily delegate to your staff. My indication for using the Nautilus system is, first of all, vascular lesions, diffuse redness, telangiectasia, rosacea, which will be talked about later on in this session here. Also photorejuvenation, hair removal, benign pigmented lesions, photorejuvenation with PDT, and photorejuvenation for acne and poikiloderma of Civat. And again, according to Dr. Cartier, this device can produce very, very short pulses as well. That means that fewer treatments are needed, and it produces equal or even better results compared to longer pulses and better control of the purpura. And again, we don't need to cool the surface. A couple of pictures here, before and just after, and after 2 months. You can see the effect here. Photorejuvenation, mottled pigmentation and skin texture. Again here, texture and freckles. Facial telangiectasias, 3 treatments with a vascular applicator. Solar lentigines, more solar lentigines here. And again, and even acne, even the active acne can be treated with the IPL system, as well as pores and scars. Hair removal, easy to do with the IPL system. There are large applicators, so you can easily do a large area in one go. Even in phototype 5, the IPL can be used for that. So you can see phototype 5 again. And a difficult area to treat is male hair on the back. But again, after 5 treatments, this is result. More rosacea will be dealt with later on, so I won't go into detail with that. Vascular malformations, again, 3 treatments. And again, not only the IPL are available, also the neodymium YAG laser, the non-ablative fractional laser at 1550 nanometers, and the same at 1940 nanometers, all 4 in the same platform. Let's talk about the YAG laser for a moment. We are using that for deeper penetration, which will be used for port wine stain, venous lakes, for fungus of the nails, and for example, for warts. These are leg veins here treated after 1 treatment, venous lake after a single treatment again. And the 1550 nanometer non-ablative fractional laser is mainly used for skin resurfacing, for coagulation of superficial soft tissue, acne scars, surgical scars, and stretch marks. Here you can see the result of 3 treatments with this device. Scar treatment is a fantastic treatment with this device. And for the 1940 nanometer laser, we are using it for skin resurfacing, for coagulation more superficially than the 1550 nanometers. And we can even use it for treatment of actinic keratosis up to skin type 3. And I just want to focus your attention on this very recent paper from September this year in Lasers in Surgery and Medicine, which actually finds that this laser creates fractional columns of injury with sufficient depth and coverage that suggest effective skin resurfacing in its own. Again, here you can see the scar in the glabella area, 3 months after 1 treatment. And again, let's look at the take-home messages. The IPL has no water absorption because it doesn't have wavelengths above 950, so you don't need any cooling device. And it's the only IPL with a powerful short pulse, which can go down to half a millisecond actually. And that makes a better control of the purpura threshold. And you do have low running costs compared to the dye laser. You don't have expensive dye kits. And you can combine it with the 1550 and the 1940 nanometer lasers for enhanced treatment results. For the YAG laser, you have enhanced treatment possibilities for leg veins and facial larger vessels, for the resistant and nodular port wine stains, again, nail fungus and warts, and it has a built-in air cooling, so you don't need to buy cryo containers or external cryo devices. Again, low running cost and no consumables. The two combined 1550 and 1940 fractional lasers, using both of them, you do have minimal downtime because it's a non-ablative treatment, both of them. They do have skin rollers for single patient use, so you don't cross-contaminate. Low running cost, no consumables, and you have the added effect of combining it with the IPL at the same time. Thank you very much.
Thank you so much, Professor Bjerring, for your overview of the versatility of this system. And may I have a question for you? I mean, do you tend to use in a single session the IPL and the non-ablative fractional laser in the same patient in the same session?
You can do that if you want to do it. Normally I space them out because I normally treat vascular problems first, and then after that, when that has subsided, I will take and look at the infrared lasers, the non-ablative fractional lasers, both of them, in the same session, and use those for skin tightening and for texture.
Okay, excellent. And if you allow me, I may have a second question for you. Do you normally use the IPL and the neodymium in the same session, in the same patient, or you also space the treatment in between?
No, those two I use at the same time because that's a vascular treatment, both of them. And I reserve the larger vessels for the YAG laser and the finer, smaller vessels for the IPL.
Quite. Okay, and that would be the sequence that you normally use. You first do a pass with the neodymium, and after this you apply the IPL?
Yes, I can. Yes, that would be the best one to do it, the best way to do it. And also, these vessels are not anatomically in the same space area.
Okay, okay. Excellent. Thank you so much for your answers.
You're welcome.
Of course, the attendees are invited to do more questions. You have the Q&A box here in our platform, so please feel free to enrich this webinar with some questions. And the next speaker is Professor Firas Al-Niaimi, who is a leading dermatologist with over 212 publications and 400 presentations worldwide. He has nearly 20 years of experience training in top UK hospitals and is the first professor of the laser dermatology in the UK. He also engages in international teaching and received the Global Excellence Award for Consultant Dermatologist of the year 2019. So it's an honor that we have Professor Firas with us, and he's invited to proceed with his speech. Hello, Firas.
Hi, good evening. Thank you very much, Dr. Barco, for the kind introduction. That's it's a great honor to be here and a Candela webinar talking about vascular lasers. Just to mention also, I work with Professor Bjerring, Peter Bjerring in Denmark at Aalborg University Hospital. So we are colleagues, and I always enjoy how he tells me about the Norlis and how it progressed and ideas. So the Norlis that we have today with all the handpieces, a major contribution has been through Peter Bjerring. So it's a great honor to be speaking right after him. So I'm going to talk about something different. I do have the Norlis platform, including the non-ablative fractional handpieces that Professor Bjerring already mentioned. But I also have the V-Beam Perfect and the GentleMax Pro Plus. And the V-Beam, in fact, is something that I was using before I had my Norlis platform. So I'm going to be the only speaker in this webinar who's going to talk about the V-Beam Perfect, because I know my other two colleagues were going to be talking about the Norlis. So let's talk a bit about the V-Beam Perfected. Before I talk about the V-Beam Perfected, let's just remind ourselves about the chromophore that we're using. And you very nicely illustrated, Dr. Barco, in the beginning, that we have vessels at different depths, with different chromophores. And this is why we have different absorption peaks for hemoglobin. So we have the 532, which is the potassium titanyl phosphate, the 595, which is the pulse dye laser, which I'm going to talk about, the V-Beam Perfected. And then we have the 1064, and because of that longer wavelength, that is the wavelength that we were going to be using for the deeper vessels, just like my colleague, Professor Bjerring, already mentioned. So this here, you can see that the shorter the wavelength, the more superficial the absorption. On the other hand, the longer the wavelength, the deeper the penetration. So in particular, if you are going to talk about superficial vessels, sometimes one of the questions is, what about the 532? And I'm going to explain why actually the 595 is a better wavelength when we talk about superficial vascular lesions. And that is because the longer wavelength, the relative longer wavelength of the 595, which is in the V-Beam Perfected, allows for a deeper and better penetration. But it also means that there's going to be less strong melanin absorption compared to the shorter wavelength. So if we compare the 595 to the 532, what you have in the 532, you have strong hemoglobin absorption, but at the same time, you have strong melanin absorption and somewhat more superficial penetration. Whereas on the other hand, with the 595, because you shift on the melanin curve absorption, so you have less melanin absorption compared to the 532, you have deeper penetration, but you still have a very strong, good hemoglobin absorption, which means that we can also safely treat all the skin types 3 and 4, and even with good experience, skin types 5, which is something that is going to be very dangerous to do with the shorter wavelengths, particularly the 532. So there's a reason why the pulse dye laser and the V-beam perfector has the 595, because Candela did look at other wavelengths, the shorter wavelengths, that is through the progression of the vascular lasers after the inception of the selective wavelength and photothermolysis theory by Professor Rox Anderson in the 80s. And Candela found that the best wavelength for superficial vessels will be the 595, because we have a good balance between depth of penetration, hemoglobin absorption, and less strong melanin absorption, and therefore we are much safer compared to the 532. So this is my approach to vascular treatment in terms of the algorithm, and of course with experience one will adapt this, but just like Professor Bjerring said, that you go with the Nautilus, it's a short learning curve and you go to the screen. So something similar I use, and that is, first of all, you will determine the choice of your wavelength. So going back to one of your questions, Dr. Barco, you asked us, how do we accustom for different depths? So for deeper vessels, we'll start with the Didac, because that is a longer wavelength and therefore we can get deeper. But for the more superficial vessels, in this case, can choose the 595 pulse dye laser. So assuming that we are going to be dealing with superficial vessels and our choices, the V-beam perfector of the 595, the first thing you would do then is choose your spot size. And you want coverage, but also depth, because we know that larger spot sizes have less scattering and deeper penetration. So when your target is somewhat deeper, but we still talk about, the depth that the pulse dye laser can reach, which is around 1.5 millimeter depth, then a larger spot size would be better than a small spot size. On the other hand, if you're dealing with a very small angiomas, very superficial, then you can customize that and use a small spot size. But one of the unique features of the V-beam perfector is that we have the 3 by 10 millimeter linear elliptical spot size. Now that is a fantastic spot size to trace individual vessels and telangiectasias. So that's what I would typically do first. I always tell my resident colleagues that vessels need to be chased. So if we're dealing with linear vessels, we can choose a 3 by 10 millimeter linear spot size, which is unique to the V-beam perfector. And then you would choose the pulse duration. So already my colleague, Professor Bjerring, mentioned that if we are doing things like port wine stains or we need purpura, then we choose a short pulse duration, so a 3 or a 1.5 millisecond. Typically for coagulation of the more larger telangiectasias and vessels, we start with a 10 millisecond and above. But particularly for very fine diffuse redness, we don't need necessarily the purpura, but we can still use a short pulse duration, but then use a fluence, what we call subpurpuric. So that is still using something like a large spot size of a 10 millimeter, using a short pulse, but then relative lower fluences. And then really with the fluence is a thermal effect, because that's what the fluence does. It's the T delta rise, which is the temperature rise. So we want a clinical endpoint. So that could be purpura, for example, in some of the conditions. That could be a color change, a little bit of darkening, subtle darkening, for example, with diffuse redness. And I do put here, do not forget cooling. I know that the Nautilus doesn't have cooling. Things are a bit different with the V-beam and the pulse dye laser, also because of the strong melanin absorption that you have, and therefore we have in the V-beam perfector the DCD that allows us to adjust the cooling. So this is how the device looks like, multiple spot sizes, and I really want to remind you about the fact that there's the 3 by 10 millimeter linear spot size. And this is, again, just to illustrate that larger spot sizes give us better depth of penetration compared to spot sizes, and this is why we tend to use the larger spot sizes if we are treating a larger area, particularly wanting some depth. And the VB Perfector also gives us many different choices of pulse duration. So we have the shortest pulse duration, which is 0.45 milliseconds. We then have a 1.5, 3, 6, 10, 20, and 40 milliseconds, which allows us to treat from fine vessels to larger vessels. The DCD, which is dynamic cooling device, so it sprays, cools the surface of the skin, and therefore allows for the light to get through the skin, which means that the skin has been pre-cooled. Now, how do I approach it in terms of the differences in vessel diameter? So typically, you're either going to be having diffuse redness, where the vessel diameter is very small, or you are going to have isolated vessels and telangiectasias, or a mixture of both, where you have diffuse redness and vessels. So, as I mentioned, vessels need to be traced. So if there are any telangiectasias, I will trace them first, and that is the unique feature of having the 3 by 10 millimeter spot size, and then I use the large spot size for the background redness. So in a case like this is exactly what I will be doing. I'll be doing the 3 by 10 millimeter spot size, starting with a 10 or 20 millisecond, tracing the individual vessels, looking for the clinical endpoint, color change, spasm, disappearance. Then I will change the spot size to a large spot size, then shorten the pulse duration, and then do a couple of passes on the entire area. So this is just highlighting. I will start with the 3 by 10 millimeter spot. And this is really just a short video showing you the clinical endpoints when it comes to diffuse redness with the VB, and that is some subtle darkening of the redness, which is what we call a transient purpura or transient cyanosis. We don't want that to persist beyond 20 to 30 seconds, and that is a good clinical endpoint that we want when we are treating diffuse redness. So some examples here, even with a mixed inflammatory type of rosacea and diffuse redness, by using the spot size with the different pulse durations and a couple of passes, you can get very nice results. There are also articles showing that the pulse dye laser reduces the Demodex count, which, as you know, the increased Demodex will lead to toll-like receptor 2 activation and worsening of the rosacea. So even the very fine redness, so in this case, it's going to be a short pulse duration. You don't necessarily need purpura. Some colleagues do want purpura. I don't like to do purpura in rosacea, but it's a short pulse duration. But the key thing here is more than a single pass. You do get better results when it's more than a single pass. Another example here, the patient had demodicosis and very nice results using the pulse dye laser. In this case, where you have diffuse redness with no visible telangiectasias, so again, it's going to be a large spot size, multiple passes, and a short pulse duration. Now, I do emphasize that this, when you're using more than a pass with a V-beam Perfector, you do need the expertise. You do need to be able to interpret the clinical endpoint. It's something more for an advanced user. If you're starting with a V-beam, I would suggest you start with a single pulse, with a single pass. Okay, I'm trying. Okay. All right. Now this. So this is another example of a classic example of something that is very common in clinical practice, where we see this diffuse redness, but we see the visible telangiectasias. And this is exactly what I'll be doing. I'll be tracing the individual vessels using the 3 by 10 millimeter spot size. And really, I have to emphasize on how unique this spot size is, the linear elliptical spot size, where you can literally trace all the individual vessels. You make sure that you have treated the vessels, and then I move over to the round spot size. Typically, I tend to start with a 10 millimeter spot and then treat the entire area. Even, as I mentioned, even tanned patients or skin types 3 and 4, because it's 595, it is safe to treat. When you find diffuse redness with flushing, I like to add in topical timolol, and I combine that with the pulse dye laser, and I've published on this. This is one of my articles on the use of topical timolol in combination with lasers. And in addition to rosacea with flushing, it can also work very nicely with post-acne erythema, hemangiomas, and pyogenic granulomas. One of the other studies that I did is combining intradermal botulinum toxin immediately after pulse dye laser for the neurogenic subtype of rosacea flushing. You can see here the injection points. This is a case where you just get this flushing with a burning sensation. So I do the pulse dye laser first. In this case, short pulse, non-purpuric, couple of passes, and then followed immediately with the intradermal botulinum toxin. Chest, neck, décolleté, back, all of that can nicely be treated. This is a patient who was referred to me who had CO2 resurfacing and had persistent erythema for months after the CO2 resurfacing, and you can see nice resolution of post-procedural erythema with the V-beam perfected. Port wine stains very nicely. And this is in the area of the small localized superficial hemangiomas when they are not a candidate for systemic propranolol beta blockers. The use of pulse dye laser with topical timolol works very well. Very briefly, and I'm coming toward the end of my talk, just a few words about using the Nd:YAG. So when you see a vessel like this, which is green-blue, we know that it's deep. So these type of vessels are not going to respond to the pulse dye laser, the V-beam perfector. So this is with the Nd:YAG of the GentleMax Pro Plus. But I have to emphasize, in this case, it is absolutely mandatory that you protect the eyes with ocular shields. You pull the skin down, you use a small spot size of an Nd:YAG. I like to place the vein between two fingers of mine, so I trap the blood flow and then just start with low fluences, just hit in the middle of between my two fingers, just looking for that subtle change, and it works well. This is a case on the temple. And this is where you can combine both the Nd:YAG on a small spot size for the hypertrophic component of the port wine stain, and then you can finish off afterwards with the pulse dye laser. But this is just to illustrate how nicely you can treat the hypertrophic components with the small spot Nd:YAG. Here again, a venous lake that was already discussed by my colleague, Professor Bjerring, so I will skip this. Another venous lake. And these venules, particularly in the man and the nose, they're blue-green, they really are a candidate for the Nd:YAG. And with that, I am finishing right on time. Would like to thank you, and yeah, happy to take over questions. Back to you, Dr. Barco.
From the audience to you, which is, do you have any experience with exosomes combined with lasers, and for what indication?
Okay, so I'm going to be very brief with this answer. The answer is yes, but not in the context of vascular lasers.
All right, may you elaborate on what indications?
Yeah, sure. I'm more than happy to answer this, but sorry, I just thought maybe we're just restricting this webinar to vascular. I use it predominantly post-healing after fractional ablative lasers and fractional non-ablative lasers to just shorten the recovery downtime and enhance the results. I know that some of my colleagues use it for hair stimulation, hair growth. I don't tend to do for hair. But my main use, which I found that the exosomes are helpful, is really in post-fractional laser recovery. I haven't really seen a huge difference in treating particular conditions, like some of the companies try to mention for their exosomes, but I do think that there is a place for the exosomes in somewhat faster recovery post-fractional ablative lasers.
Thank you so much, Firas. So last question from me and about vascular lesions. Are there some indications where you specifically search for purpura?
Yeah, I mean, that's a very good question. And I do, yes. So I typically, with port wine stains, if I'm treating with, particularly with the pulse dye laser, I do seek purpura. Now, there are different shades of purpura. So depending again on the depth of the lesion and on the skin type of the patient, will chase either a light purpura or sometimes a little bit more of an intense purpura. But we know from multiple studies when it comes to the pulse dye laser, all the studies that looked at purpura versus no purpura showed superiority with purpura, but this is with a pulse dye laser. Things might be a bit different with other modalities. So I have to stress that with the pulse dye laser, purpuric mode gives better results compared to non-purpura when it comes to port wine stain. For hypertrophic scars, I do like very light purpura for thick hypertrophic scars. Keloids also, although with keloids I do combination treatments. For warts, verrucas, I do like to get the purpura. And then if I'm treating small, flat, superficial hemangiomas, which really is the only indication for pulse dye laser, in my opinion, when it comes to hemangiomas, the flat, thin ones. But in that case, I'm looking for very light purpura. So the purpura is much lighter for thin hemangiomas compared to port wine stain. And this is important because if you get intense purpura with the hemangiomas, you can actually sometimes go more in ulcerative mode and you get some ulcerations there. So hemangiomas, port wine stains, hypertrophic scars, and warts, these are my classic vascular examples where I would want some purpura.
Thank you so much for sharing your experience, Firas. And now we're going to move forward to our next speaker, who is Jelena Jeftic. She's a dermatologist from Belgrade, Serbia, with training across Europe and specialization in dermatovenereology. She works in private practice focusing on clinical and laser dermatology and has published multiple scientific papers. She is a member of various dermatological associations, including the European Academy of Dermatology. So she's now going to focus in advanced laser techniques for achieving optimal vascular outcomes. So Jelena, we are yearning to hear your speech, and there we go.
Thank you, Dr. Didac. It's really a pleasure to be in this webinar, and thank you, Candela, for inviting me. So let's start. Let's start from primary vascular lesions. As we know, rosacea is one of those type of primary vascular lesions, and these are some of the clinical features of rosacea. So in the pathogenesis of rosacea, it's like multi-etiological, and it has many steps in the pathogenesis. So also, there are some major and secondary phenotype. Patients always complain about burning, stinging, edema, and also it's very affecting the social life of these type of patients. So IPL and lasers, they have their own place in treatment of rosacea. So let's start from the patient. So this is the patient with erythemotelangiectatic type of rosacea. As we see after the first treatment, we see a beautiful results, a reduction in telangiectasis and also in erythema. This is the other side as well. And this is also a very young patient with erythemotelangiectatic type of rosacea. And when we see all these lists of parameters, we could say, oh my God, what is this? It's too much. But it's not too much because I really like to optimize the treatments. And I always use dermoscopy. It really helps me to navigate the treatment. So as we see in the third session, we combine many of IPL treatments and also NDIAC. So for example, in the cheeks, she had telangiectasis and erythema. So for the first treatment, I always target vessels. And then after erythema, on the nose, she had some resistant vessels. So we used NDIAC. And in the forehead, we used IPL. This is a patient without any topical and oral treatments. As we see, very nice reduction in erythema and telangiectasis. This is a patient with a very long-standing rosacea. She tried several type of treatments, including IPLs and also lasers. And also for her, when we see in dermoscopy, she has a very thick type of vessels. So in this video, I wanted to show how nicely we see a clinical endpoint. We call it transitional graying. As you can see, all the vessels just change the color. In her case, I started with a VL handpiece because she had thick telangiectasis and also very prominent redness. After, in the second session, we moved to PR handpiece and also combined it with the Nd:YAG for resistant vessels. So when we see this photo before and after, I could say I'm not so much satisfied with the results, but when we look closer, we see that all telangiectasies are removed. So she now had her fourth treatment, so I'm really looking forward to see the results. Also, in young men, erythemotelangiectatic type of rosacea, as we see also in dermoscopy, we see a very nice reduction in erythema and telangiectasis. Also, when we have only telangiectasis, we also see a nice reduction of very intraocular graying. And this is a type of patient with a very severe actinic damage. On his cheeks, we see telangiectasis, and also on his neck, we see poikiloderma ossivat. So after one treatment, we achieved very nice results. Also with the facial telangiectasis. And this year in April, we published very nice clinical bulletin with nice cases of rosacea, so you can still look and find something interesting. One of the factors of the rosacea is also Demodex. We see Demodex very often included in rosacea patients, and we see it more often in the papulopustular type of rosacea. And when we see this patient, unfortunately, she was treated for a long period of time as acne. So unfortunately, therapy didn't work. So she had rosacea and she had hemodicosis. After 2 treatments with the IPL and with the oral ivermectin therapy, we achieved very good results. Again, the hemodicosis associated with rosacea. Also, we can combine topical treatments. Here in this case, we had the topical ivermectin. This is in the other side. And also topical ivermectin after 2 treatments with the IPL. This was one of the most resistant type of rosacea, so she had also topical ivermectin included. This is after only 1 treatment with the IPL, PR handpiece, and this is without any type of topical or oral therapy. And when we see this patient, she also had hemodicosis and rosacea, but after 2 treatments with the PR handpiece, we see a very nice improvement not only in rosacea but overall in the whole skin. This is also after 1 treatment, rosacea and hemodicosis. This is a type of papulopustular rosacea, also included with hemodicosis. We see in dermoscopy little small white pustules on the forehead, and this is after 1 treatment. Again, the rosacea as well. And let's move to capillary malformations. The first will be port vein stain, and everyone who ever treated the port vein stain in adult period knows how hard it can be. So these group of patients are very sensitive, and mostly they tried many type of laser procedures as well. So after 6 treatments here, combining VL with the PR handpiece, we achieved very, very satisfying results. Also, some of these patients can have facial asymmetry. and we see a reduction in asymmetry after one treatment. Also, I like to follow these type of patients with dermoscopy. It really helps me to navigate the treatment and to see clearly where are the vascular lacunas. And this patient underwent many procedures, but she had before maybe 20 years ago, she had some electrode restriction therapy, and all these white spots on her neck are basically atrophic scars. We see also very nice improvement after 3 treatments. This patient also had more than 20 pulse dye lasers. So this is after 2 treatments where we see a very nice reduction. Also patients who underwent many type of procedures have beautiful results only after 1 treatment. Again, centrofacial port wine stain combined with the topical timolol. And one nice clinical study where they followed all the patients with port wine stain from the childhood to the adulthood, and we see moderate hypertrophy of the port wine stains. Also very nice clinical study when they followed histology. And hemangioma also can be hard to treat. So this is the patient with a centrofacial hemangioma. After 3 treatments, we see a very nice reduction in erythema, in telangiectasis, and also the surface is way much lower. Again, patients with the hemangioma, as we look at in dermoscopy, we see a nice reduction. Patient after only 1 treatment with the VL handpiece, and beautiful reduction. Also, something that we see very often is spider angiomas on the face. Again, I also follow it on dermoscopy. So the second photo is immediately after, where we see erythema and edema, and the last photo is after 2 weeks, where we see complete clearance. Also, when you follow it on dermoscopy, we can see different patterns of spider angiomas. Lip telangiectasis, we also can treat with the PR handpiece, and something that we combined with the VL and Didac handpiece for facial telangiectasis. Again, and nasal telangiectasis, please be careful with the NDR handpiece on the face, since we see a lot of atrophic scars, unfortunately. And this is dermoscopy where we see a complete clearance. Yes. And this is a short video just to show how it looks. So procedures is basically a little bit uncomfortable. We have a soft cooling, so it really helps the treatment and to the patients to feel more comfortable. Okay. We can go. Okay, and this is a patient with the periorbital veins. The second photo is when we pull down the skin, we see more prominent vessels. And the last photo is 1 year after, so we see a complete clearance. This is on the other side as well, followed by dermoscopy. And the first video is the video before, and the second video is the video after 2 treatments. So also be careful. These type of patients have to wear intraocular shields. Okay. Mm-hmm. Okay, and this is the other side as well. Yes, so when you pull down the skin, you will see a prominent periorbital veins. And on the other photo is just the complete clearance without any atrophy or redness. Venous lake is something that we also see very often. So just be careful when you do this procedure, isolate the lesion. And nasal telangiectasis combined VL and NDR handpiece on the other side. And when you treat like vessels, the immediate response is erythema and edema. And here in this video, you can see how the procedures looks. I like to say that this is my favorite handpiece. I worked before with the GentleMax Pro, and I prefer this handpiece on the Nordless, definitely. Okay. So immediately you see complete clearance. Okay, we can go to the next one. Yes, again, a short video just to see how it looks on the different type of telangiectasis and thickness and color. So yes. Okay, so we can continue. In this photo, you can see just after one procedures with the NDAG, and as well on the leg vessels with the Nordlis with the NDAG handpiece, very nice reduction on the extremities. When we treat as well truncal vessels, we use NDAC. So unfortunately, this was a steroid rosacea, many years of using topical corticosteroids, as we see reduction in erythema and telangiectasis. Also, we see post-inflammatory hyperpigmentations after acne combined with the non-ablative fractional laser in the same session. Acne conglobata and post-residual redness we can treat as well with the PR handpiece. And this is some food for thought. This is a patient with traumatic keloid scar on the face, and here this young patient is in the process of treatment, so I'm really looking forward to see him. Definitely in his case, we combine procedures, PR with injecting triamcinolone acetonide. And unfortunately, also he had some keloid scars on the trunk, as we see 3 keloid erythematous scars. After 2 treatments with combining procedures, we see complete clearance of 2 keloid scars and only 1 post-residual. Also, with the surgical scars, we can combine VL handpiece and non-ablative fractional lasers in the same session, as well after a blepharoplasty. And with the severe actinic damage, we can also combine procedures, but in her case, we start with the VL and combine with the PR and NDAC handpiece. Also with the very rare conditions such as granuloma faciale, we can use a PR handpiece. And if you are doing aesthetics, usually in the face, you see very much hematomas. You can use as well IPL handpieces. And that would be all for me. Thank you so much.
Thank you so much, Jelena. What a nice collection of cases and good results and pictures. Thank you so much for sharing them with us. We are running out of time a little bit, so we're going to move forward with our next speaker, which is Dr. Lukic. He's a certified aesthetic medicine doctor and ophthalmologist specializing in oculoplasty. Dr. Lukic is the vice president of CZM and currently practices at Una Residence Clinic, where he combines lasers, injectables, and surgery to achieve optimal patient outcomes. And we are eager to listen to his speech. So please, Branislav, you can proceed whenever you want.
Well, first of all, great lectures, everybody. It's really an honor to be here, and thanks to Candela for this opportunity. My colleagues did an amazing job about the introduction part, about the theory, about the specific, so we can just do the cases. So just to again reconfirm, the Nordlis system has dual filtration, sub-millisecond pulses, clinical intelligence, silent, remote assistance, and no cryogen required, and treating, of course, all Fitzpatrick types. Okay, so this is the adult port wine stain, as Jelena said. I used here first VL because it's darker, then I switched to PR, and then I started using non-ablative fractional laser because these kind of changes on the skin can leave a scar if you're not careful and not doing the frax laser right after it to prevent the scarring. Here you can see the telangiectasias and venous lakes on the next slide. Are also the same, PR, VL, and then ND-YAG with great results. And also, I might say that there is practically no downtime apart from some erythema and swelling. Here we can see the venous lake on the lips. Again, one more venous lake. You can see that it's just a couple of days and there is nothing, not a scar or anything, because mucosa really heals fast. Okay, this is the beginning of rhinophyma, and when you use combination again, PRVL, the light with fractional laser, then you can reduce the tissue, and then you can prevent rhinophyma from ever happening. And it's really nice way with practically no downtime to deal with something so serious. Nose telangiectasia, everybody showed already. It's super easy and it's super nice to do. Also here, and here was underlying, it was hidden rhinophyma that we're still treating. So sometimes you can miss the proper thing, but in the end, you treat it with Nordis anyway. Also again, telangiectasia on the nose. And as my colleague said, we can treat active acne at the same time with the scarring. So it's really nice to combine light with fractional lasers. And also once we use 1940, we can really apply the active substances, topical therapy much deeper after we use 1940. This is when we have a combination of vascular changes and depigmentation, and you treat all in one treatment. Sorry. So this is when we combine the light with ND-YAG at the same time to get this amazing result. And this is only 2 treatments. So first we always do the ND-YAG, at least in my experience. Sometimes it can help if we say to the patient to put the air in his cheek or her cheek, and you can visualize easier the ND-YAG. We have to be careful about all these vascular changes on the face, not to press the applicator too hard because we can make extravasation and then miss our target, which is hemoglobin. Again, this is the same person, just in a better shape. Here were all hemangiomas. Hemangiomas are really easy to treat, either with IPL or with the ND-YAG on Nordlis. Again, this is how it looks like immediately after, and then it passes like nothing has happened. So this was a hemangioma on the elbow, but I miscalculated, didn't know that they can bleed so much even after ND-YAG. So this was a bleeding on over half of the room. So we have to be careful about that sometimes when we treat those kind of vascular changes. Since I'm an ophthalmologist, for me, hemangioma on the eyelid is super easy, and mandatory is to use intraocular shields because ND-YAG laser, we cannot see it, and at the same time, it makes granular tissue in the retina completely destroyed. So we really have to be careful with using ND-YAG for periocular region. This is what my colleagues also showed, periocular rejuvenation. I'll show you the video how it works, always with intraocular shields. Here as well. This is immediately after the treatment. You see it's a little bit erythema, but nothing special. But sometimes periocular region, because it's a very thin tissue, can really swell up like basically like a bag filled with water, but it goes away super fast, and the next treatment is less dramatic. Poikiloderma of Sivat. We can see here, I always combine with non-fractional lasers. non-ablative fractional lasers 1940 because it really gives me the extra shine I need, and also it provides me with the opportunity to use topicals locally. Here as well. Here we can see hemangiomas and capillaries on the chest since she was a child. And basically I'll use here as well fractional laser to prevent from scarring. Here we have a situation where a patient had a CO2 laser, but somehow they missed that she has rosacea as well. So she has really post-inflammatory hyperpigmentation, this redness, which was resolved only with 2 treatments. And I triple checked with the patient that she doesn't wear makeup. Here we can see the sides as well. Here you can see, spider hemangioma was on the nose, but we cannot see it on this slide. Also periocular hemangioma, spider as well. The NDI has this sapphire tip, which when you push, you can really identify the feeder vessel and then just destroy that one with much less trauma to the tissue. Leg vessels are really nice to use, to deal with NDIAG, and it's almost like a magic because it disappears, as Jelena showed, directly in front of us. I would just add, we really have to make sure that the patient afterwards wears compression socks, and in my opinion, also the aspirin for next month to have a lasting result. Here also we have capillary telangiectasia with rosacea, also combination with non-ablative fractional with 1940. This was already. And here we have extensive redness with telangiectasia, where you can see the removal of all the tiny vessel on this black and white photo, how it looks like when you enlarge it. And it's really nice, but this patient will have significant swelling tomorrow. Also here, rosacea with the scars, and it's really dealt nicely. Here, I started to reconsider and started to use in my practice skin boosters at the same time to strengthen the dermal barrier in the skin and to enhance the results even more. Here as well, older patient. So now we can do videos. We can just shortly play this one. Here is the telangiectasia from the leg, just disappearing very nicely with the NDR. We can go to another video because my colleague has already shown this. Okay, here we have a combination treatment, how it looks like. First with using the NDR and then with using the light at the same treatment without any fear that something might happen with the patient, because also, as my colleague said, IPL in Nordis is extremely precise and doesn't absorb the water, so we are more carefree than with some other lasers. So as you can see, you do everything, the entire face at the same time, but without any fear that it will be too much for the patient. We can go to a next one. Again, so just one take-home message is to not to press this light too much, this applicator too much in the skin, so you don't cause extravasation. You can go to the next one, please. Here we can show how it looks like before and right after the treatment with this erythema and with with just profuse erythema after the laser without any visible telangiectasia at the end. We can skip the next one and go to the second. We can skip this one. because my colleagues already showed, and I'm trying to be on time. So this is how it looks like with the periocular veins. And I think in this video, there is how I applied the corneal shield intraocular. You see this nail, as my patient said. This is the corneal shield, which is metal, which really saves our eyes. I would just really like to say that sometimes when we do this, patient might have, after a month, really bruise suddenly appeared in periocular region if we left some kind of small part of the blood vessels still intact. We can skip this one as well. I just want to show ocular rosacea and I'll be done. We can also skip this one. Sorry, my colleagues were very detailed, so I didn't. I kept all my videos, but basically I just want to show the important one. So the ocular rosacea and the dry eye is very much connected. And as an ophthalmologist, I'm very relaxed when treating this area. You saw the placing and application of corneal shield is pretty much easy. And Nordis has this great double pulse, and then after that double pulse, we can make it short to 0.5 milliseconds, as the professor said, and really deal with this nice diffuse redness around the eyes, and the results are almost immediately thereafter. And it's really nice and without any kind of antibiotic drops afterwards. All right, with this, I can finish my lecture. It was a big pleasure, and we can go through Q&A.
Thank you so much, Dr. Lukic. We have a few questions here coming from the attendees. I have selected 4 of them. And the first one is it always better to use a spot size a bit larger than the actual vessel size? Firas, what's your point of view on this?
Yeah, thank you. I mean, I think that's, so it depends on what device you're using, because when you are using, I assume this would be applicable to the pulse dye laser and the Nd:YAG. For the pulse dye laser, as I mentioned, we have the 3x10 millimeter. So that will really get you pretty much all the vessels that can be treated with the pulse dye laser. So the 0.1 all the way up to the 0.3 millimeters. So that will be fine with the 3x10 millimeter. When it comes to the Nd:YAG, now you really have to be careful using a large spot size. So I would prefer on the face to use a 1.5 millimeter. Now, if you are experienced and with great care, you can use the 3 millimeter, but I wouldn't go beyond that. But you will find that even if you're using the small spot size, you can still get the contraction within the vessel. So for the pulse dye laser, the 3x10 millimeter will suffice for all the red vessels that the pulse dye laser can treat. When it comes to the Nd:YAG, you have the 1.5 millimeter spots, you have the 3x10, and the largest you should go on the face would really be the 3 millimeter.
Okay. All right. Thank you so much, Firas. There is another question directed to Jelena, which is, which parameters do you use for hematomas when using an IPL?
Well, usually I'm using the rosacea settings. I don't change anything. I just stay on the default settings.
Okay. So with the rosacea settings, you mean the ones with just the, you know, the pink spot with no vessel on it?
Yes, yes, yes.
Okay. So the shorter the pulse, right?
Yes, yes, yes. On the face, yes.
Okay, excellent. And do you think then that with just one single session, there is a big improvement in hematomas with these
Yes,
settings?
it is. Definitely it is. Usually, I did only once. Yes, usually
Okay.
did only
Great.
once.
Yeah, it's not a very common treatment to be done. Do you remember if you use the PR or the VL handpiece?
Well, it depends on the skin type, but mainly here, yes, I use PR.
Okay. All right. Thank you so much for your insight. There is another question. When treating diffuse redness with Nordlis, when do you choose double pulse structure and when single short pulse? And do you combine in the same session and in which order? So we have 3 questions in the same sentence. Dr. Lukic, what's your take on this?
Well, since I'm not a dermatologist like my dear colleagues, and I cannot really see the depth, I use it all. And it's always giving me the best result with topical therapy included. So first I use the double pulse, and then I use the short pulse for the nice diffuse redness everywhere, as the same as the double pulse. And then I give patients topical therapy in terms of like ivermectin, metronidazole, and azelaic acid, anti-tranexamic acid. And that's giving me really good results.
Great, excellent. Dr. Bjerring, would you like to give us your take on this last question? Do you tend to use double pulse structure or just one single short pulse? And if you combine them, what should be the order of them?
I definitely use the single short pulse first for diffuse redness. And I think that actually is very effective. Especially if you're using the PR applicator going from 530 nanometers up to 750 nanometers, and that is actually extremely effective for diffuse redness. For the double pulse, it's mainly constructed in order to produce methemoglobin, as you mentioned in your talk, which again will hit another chromophore, which is the methemoglobin made artificially for this purpose. And that gives us an opportunity to actually reach a little bit deeper vessels, because you actually can have small vessels located deeper, not only in the surface. Therefore, that would be a very good option for that.
Okay, thank you so much. There is also one interesting question here, and it's a general question, so any one of the speakers feel free to answer it. Is there any risk of hair removal with the PDL, or is it so superficial that the wavelength will not permit it? And the same question with PR and VL handpieces. So who's going to answer this question?
Well, can I answer at least the PDL part, and then I can let my colleagues answer the Nordlis part. So the 595 is not a hair removal wavelength. It's not a wavelength that is absorbed really by the follicular melanin unit. It's way too short wavelength for that in terms of depth of penetration, pulse duration, critical fluence to get coagulation and necrosis of the hair follicle. Studies have not shown any destruction and coagulation necrosis to the hair follicle. So with a pulse dye laser, I would say you're fine, and I'm not aware of any reports also of hair removal. I have used it 100 times, including on the face, hair-bearing sites. I've never observed long-term hair reduction. So the answer will be no.
All right. Anyone experienced with accidental hair removal with PR or VL?
I have treated a lot of port wine stains in hair-bearing areas in the face, and I do see slight reduction in hair growth in these areas, but that might also be due to the original lesion, the vascular malformations and the hemangiomas. So it's difficult to say whether it's the original disease or it's the treatment that actually reduces hair growth in these areas.
Great, excellent insight. I have just two questions for you all too. Do you tend to use the PR and the VL handpiece in the same session, or you try to space them? What's your take on this?
My take is that that if I can, I will use the PR applicator, because that, in my opinion, is a little bit more effective, but it's difficult to use in darker skin types, and that actually restricts its use for the darker skin types. Whether if we have lighter skin types, as we do have here in Scandinavia, we will use the PR applicator and get a slightly better treatment effect in one go. So I don't need to mix them, basically.
Okay, great. Any other take on this?
Sorry, I have to say that I combine VL and PR handpieces when I'm treating port-fine stains, mostly, because it depends of the lesion, of the color, and I like to combine it. And also when I'm doing test spot, I usually combine it because I want to see where I will get the purpura. So that's the main indication where I combine VL and the PR.
Great, excellent. And can you elaborate on what's the sequence of the hand pieces that you use? You use first the PR and then the VL?
Yes, I use VL first and then I use PR.
Okay, so you go from depth to more superficial lesions, right?
Yes, yes.
Okay, excellent, perfect. So if you allow me just one final question for all of you too. As far as I'm concerned, or in my experience, there's a lot of edema after vascular treatments, especially with rosacea. And I would be very pleased to know, how do you manage this edema after the treatment, for example, of rosacea with an IPL? Do you use topical treatment? Do you use oral treatment? You don't use any treatment to manage this? So what's your take on this?
I can start.
Okay, well, sorry.
Sorry, Professor. For me, it's just easy. I first immediately use the compression, cold compresses, and then I give these enzymes that dilutes the swelling afterwards. That's all.
All right. Excellent. Any other take on this final question? Maybe for us?
We are using... Go on.
Sorry, Professor, yeah, you go.
I'm using cold packs, not freezing cold, but only down to 0 degrees, and that actually reduces the swelling. And then I'm using a phytomask, a green cooling gel afterwards.
Okay, thank you so much. So most of you tend to use cold to manage this edema. Okay, so on behalf of Candela, I would like to thank you for your participation in the virtual meeting. Thank you all. Thank you to the speakers and the attendees, and see you soon. Bye. Enjoy your evening.
Bye. Bye.